Hi, I'm Dr. Derek Lee. It's once again my pleasure to introduce Dr. Hagit Berdishevsky, who's a doctor of physiotherapy, a Schroth instructor, and a level 2 certified therapist who specializes in scoliosis and spine rehab for non-operative, preoperative, and post-operative patients of all ages. Dr. Berdishevsky, I'll pass it over to you, and you can share your presentation with us today.
Thank you. Good. So now we're going to talk about the exercises, suggestion, what is sort of the protocol that we use. So let's begin with the fact that there is not a lot in the literature. There's not a lot. There is coming, there is more, but not a lot about rehabilitation and early rehabilitation after spinal fusion. But of course, the integrated program and early rehabilitation improve out the function and shorten the hospital stay, which is also important to the hospital management, with less complication, less pain, better patient satisfaction, and early return to activity. From a meta-analysis on pediatric return to sports after spinal surgery, found little evidence to guide practitioners on return to sport. The mean return to sport was 7 months, and you can see the different authors on this slide. Distal fusion, meaning fusion in the more towards the lumbar spine, was a predictor of successful return to play. The survey of spine deformity study group found most recommended running at 3 months, non-contact sports and contact sports by 6 months, and collusion sports by 12 months or not at all. I'll talk to it in a second about it. Tarrant et al. Follow about 77 patients who had posterior spinal fusion until they reached return to prior functional ability, and they found that 51% of patients returned to unrestricted activity by 24 weeks. Part-time return to pre-operative level or better on average was 11.5 weeks. So, and these are more the teenagers. The harm study group will be investigating return to function following fusion. This is one of their goals, but still there is not too much. In terms of the protocol or the exercises, it is very important to state that it's individual and activities must be cleared with the surgeon because its time depends on comfort level of the patient and the surgeon comfort level of the therapist doing and yeah. So what I'm going to say here are guidelines that we develop at Columbia University Medical Center in New York, along with Dr. Vitale and Dr. Roy Lenke, and my best, greatest friends, Schroth, also best Schroth therapist, Kelly Grimes and Prachi Bakarania, who are left to take care, they're taking care of this clinic in Manhattan. So before we even again start, I want red flags or refer out, meaning the therapists need to know, the patients need to know. If you develop a new pain or a sharp pain, a pain that you're not used to it, go back to the doctor. If there is change in the shape of the torso, something that doesn't look to you like was yesterday, go to the doctor. And clicking noise also to find out what they mean. When I spoke to Dr. Lenke and I interviewed him for about an hour, he gave me from his time, and we spoke about return to function and sport. So what he said is that with appropriate surgery, with optimal alignment, and avoiding serious complication, even older adults can live a very normal and active life. Certainly from a therapeutic perspective, working to optimize core and trunk strength and both unfused spine and other major joint motion is important for these patients. And addressing the pain is very important as well. So if I will get his permission, I'll send you the recording, and maybe we can post it along this presentation. But he is very supportive of preoperative, postoperative. He sends his patients, he tells his patients to exercise, he returns patients fast for sport. So in terms of return to sport for adolescent, it is faster and quicker. Typical surgical pain relief at 3 to 6 weeks. Usually outpatient physical therapy after 6 weeks with a surgeon approval is a good time to start physical therapy, 6 weeks. Mostly they heal by 4 months. Usually kept on activity restriction, maybe for 6 months. What are the restrictions? Probably collision sport, sports if you have pain. After 6 months, pain is your guide, it's your guru. Listen to your body. If practice and drills bother, then stop and do not compete, or stop the activity and return to a little bit more for stability. Adults, they have a little extended period of recovery. They don't heal as fast as the adolescent idiopathic scoliosis. There is also apprehensive of movement, a very important point here, because we need to actually encourage the breakout from this apprehensive of movement, which can also happen with adolescents, yeah? The apprehensive of movement is typical, even for us. When we have an operation, we don't feel like we want to move. We're afraid that something will move, that we are not strong enough. We stay longer in bed. The function of the body is diminished. And then stability is also, body needs to be active every day to maintain. How they say it, something, you lose it. You don't use it, you lose it. So it's important. And adults, we need to give them confidence that they can get out of bed, they can function, they can walk, and do some exercises that are even just in bed or in the chair. Early on, need to avoid twisting activities like golf, tennis, heavy weightlifting. Healing usually takes 9 to 12 months and up to 2 years. After 1 year, if no pain, they can resume normal activity. Now, regarding the golf and the tennis, these are rotational movements. So when the patient is, for both, for adolescent and adult, right after the operation, usually it's, I think, 8 weeks, that the surgeon asking not to do bending, lifting, and twisting. They call it no BLT, bending, lifting, twisting. And that is to protect the fusion. Later, we are the therapists, have the goal and the role to teach the patient how to go back and play tennis and golf, and basically move and rotate from the foot and the leg and the hips, and try not to twist and rotate, of course, the fused area, which will not be able to do anyway, but we guiding the patient, the movement from the other joint. And that's also why now these joints are going to be more overworked, and therefore we need to teach the patient how to move from there, create movement, and also stability, to stabilize these areas that will take more movement now. Yes, so the therapy goals to assist with general mobility and range of motion, increase ribcage mobility and proper breathing mechanics, increase self-awareness of body in space and joint protection, as I just said, find spinal neutral, including shoulder, hips, head, and neck, strengthen in a balanced, elongated position, promote global balance, stability above and below the fusion to prevent this adding on and the generation of these areas that take more pressure, improve scapular alignment and shoulder function as needed, often related to the rib prominence. And the doctors, they don't work on, they don't do anything with the scapula and the shoulders. And this patient with scoliosis, they have one shoulder protruded forward and the shoulder blade also a little bit going upwards. The other shoulder typically sinking down into the concavity. And the muscle have malalignment, and therapists can work on creating stability around the shoulder region as well as the hips, the joint above and below that function for movement. Improve and control pain, there's a goal, and activity of daily living and recreation. So it's going to be phase 1 is the preoperative basically. And then we start right at the hospital with active postural control, trunk stability, teach patients to use their own ability to use trunk musculature as a brace, activity of daily living training with a fused spine and education of the joint. Let's see, I want to show an example here of return to sport pretty fast. That's the patient, scoliosis on the left, a fusion, a selective fusion of the thoracic region with her normal leftover lumbar that probably came down even from 51 degree here to 27 degree of the lumbar. And then you see her from the side. This is the patient, preoperative, this is Dr. Lenke patient, he posted it. And we can see the improvement of the trunk and the pelvis and even the prominence. And this patient is here about 3 weeks post-operative. This is 3 weeks post-op of the thoracic region. Courtesy also for the patient. And this is her 4 months post-op, Virginia High School State Championship, 2nd place in 200 meter. And this is another patient with a double major fusion, Lenke type 3C. Also the lumbar and the thoracic were fused here. We can see her prior on the left and post-operative on the right with good strength and exercises post-operative.
Started swimming after 3 weeks. And then after 5 months, I was playing softball again.
And so she also was a swimmer and softball, and she started pretty close after. This is a table that we created at the Columbia University Medical Center to guide return to sport. And we can see that most of the sports within 4 weeks, patient can return as if they feel comfortable. And more of the collision sport, the ice skating, the skateboard, we hold them maybe until 3 months and then we allow them to do it, just because of the more risk of fall and maybe fracture for the fusion. So the rest, swimming and lifting weights and the light workout and dance and yoga and gymnastic and all of that, horseback riding, you can do when you feel comfortable. I want to say this is almost the new guideline. When the patient feel good, no post-operative pain, and also confident enough. It's important. So phase 2 is week 0 to 2. Suggested goals is to transfer in and out of bed independently, sit for 1 hour with a back support, walk for half a mile, and do all the self-care independent. There question, if I keep it here on this screen, is it gonna disturb your cutting the other place?
No, not at all. I'll be able to crop to whatever. So you just go ahead with whatever you're comfortable with.
Okay. So phase 2, phase 1 was the preoperative. You remember, phase 2 is basically starting right after the surgery for 2 weeks, more functional exercises in bed, lifting the buttocks, maybe moving the legs, getting out of the bed. And then phase 3 is from 2 weeks to 3 months postoperative to relieve pain and stiffness, to respect the tissue healing, and start postural exercises, core stability, neutral tension, balance, proprioception, endurance training. And then there is this list of things that maybe, Derek, if you want, we can somehow have a link or in some way we can give this as a PDF for people who are interested in the guidelines, or maybe you can refer them to, we will see how it works. But week 2 to 4, aerobic, stationary, bicycle or treadmill, 15 minutes, starting with gentle sitting, standing, walking for alignment in front of a mirror, from sit to stand, submaximal core stability with leg movements, a knee fall out. There are different exercises that therapists know how to guide for core stability, some nerve mobilization in lying down, lifting the leg, exercising side lying for hip dissociation, postural exercises, balance training, and give home exercise program. This is, you can see, 2 to 4 weeks post-operative. This patient needed basically to learn how to stand. You can see him on the left, more tilted, and then using the poles and the Schroth principles. And then after a few weeks, he is able to hold his trunk in a conscious upright posture. Here is also a girl that you can see how she performing the Schroth walk. The Schroth walk exercise, we're teaching it without operation for everyone. And maybe this is the point to say that we use the Schroth, I use the Schroth, I teach my therapist to use the Schroth method, not just for non-operative patients, but it is a beautiful way with great principles to strengthen the body and to balance the body after an operation. And really, I use the principles of also for myself. I do a lot of the exercises, and for patients that come to me with a disc herniation or spinal stenosis or any other spinal condition. So what she's doing post-operatively, she's basically walking in an elongated and expanded, she's moving forward on her toes, going up and down. I'm trying all the time to observe and see, guide her that she needs to move her trunk a little bit to the left. You see how it works on balance. And even an athlete after a fusion needs to go on their toes during the short walk. It's right now, she required to stabilize and strengthen the legs and lengthen the spine and expand it. And walking on your toes, the Schroth walk is an incredible exercise from toe to head, via the shoulder and the rib expansion. You can see I guide her and she sees herself in the mirror. And you create a positive tension of exercise in the body. And also we did it just basically standing with the 2 poles. She's standing and I am guiding her where to expand and what to do. Right breast forward, a little side shift to the left. And this is your best alignment. Elongation. The therapist really stand and guide where. She have a right chest, opening the left side. Attention more to shift her trunk to the right, and I would like her to be, of course, upright. So I'm guiding her to expand her left rib cage, to lengthen, also via the shoulders, opening the shoulder, the Schroth position of opening the shoulder, we call it shoulder traction to the side. Again, as I said, it takes really also the whole fascia around the trunk and expand it and create stability, muscle action, and length. Very, very important. Lying down, leg movements with emphasis of maintaining the core stable while only dissociating leg movement. And sit to stand, wow, sit to stand, everybody, is a wonderful exercise. It all depends what you give into the exercise is what you get out of the exercise. I love the sit to stand exercise, and maybe I'll take a second pause here to show you a video of sit to stand where you can maybe relate to it and do something like that. And I will explain what I'm showing here. We inhale and we go forward. In that position, I typically ask to even lower the legs a little bit. So the quadricep works, the erector spinae work. This is an advanced sit to stand. Not sure that 2 or 3 weeks post-op, one will feel comfortable because there is a lot of tension here when the trunk leans forward. All your back muscle work to stabilize you. I ask to co-contract the abdominal, to bring the chest forward, lower the shoulder, lengthen the back of the neck, arms pointed forward, also create stability. So the whole trunk is on action, basically. And we leave. And then from here, slowly I stay maybe, and I come up and I lengthen. I did it, it's forward fast. So maybe you sit a little bit fast. We lower the heels and we bring the arm to horizon and slowly we come down. On 5, all the time, 5 seconds that you go down, 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 your body is working. Down, we hold the and again, coming up slowly, come on your toes, elongate, expand. Excellent exercise to do it for everyone, really, not just post-operative, but for sure it's a great strengthening. Doing it in front of a mirror is even is better because then you can see yourself. From here, later, when you advance, you can do it even with an elastic belt. With the elastic belt, you basically doing the same, just creating more activation, more tension, more work. At 4 to 8 weeks, as I said, maybe the sit to stand with advanced tension, you do it a little bit later, maybe now. But again, it's a harmony between, it's a dance between the therapist and the patient, me seeing the capability of the patient. Everyone is different. Then we advance the aerobic to 20 minutes a day. We advance the core stability with more progressive exercises. We're doing some hip flexor stretching, quadruped walking, I'll show you in a moment, more balance training, and everything needs to do also home exercise program. So patient can do quadruped, can use elastic belt, can go on a balance board. Here, my patient is, I'll come from this one. My patient is 4 to 8 weeks, and bearing weight through the arms and the legs, knowing how to hold the spine like that is also important. I recognize that she had some difficulties maybe straightening the arms. So it's also good to work on it, lifting of the arm against gravity before we progressing maybe to plank exercises like that. Let me see here, teaching her some planks. Planks are the best core stability exercise known by literature as well, and very, very safe. So we did these exercises. At 8 to 12 weeks, we continuing with aerobic up to 30 minutes a day, continue with progressive core and lumbar and trunk stability, planks, side planks. Again, very individual. Not everyone can do it 4 months after the operation. So everything that I say here and show is not to try by yourself. I should have said it at the beginning. Every exercise that you see here, this protocol is based on us, our experience, and work one-on-one with the patient. So you can see some example, lunges, can do squats as well. Phase 4 is basically months after the operation. Can do progressive Schroth position, advance your balance, start to do lifting according to the surgeon recommendations. Here I'm doing some Schroth exercises because I love the positions. I love to challenge them. I love what I can apply. And basically it's all about expansion, and expansion creates stability in an open, elongated trunk. Here we're doing some semi-hanging exercise. And here again, the therapist is sitting, still can work on the prominence. It's a very hard exercise to do it this way because your quadriceps are working. Then this is the hardest thing here, to hold with the quadriceps and with the shoulders. This belt is connected to the wall bar basically. In the middle, you can see here also making my patient being upright, trunk over pelvis, and then bilateral shoulder or elastic belt pull out. In the pull out, we work on elongation and then side to side. And we progress to work on the Bosu on the left side. You can see the Bosu with stability. She does squat. It's usually shaking in the beginning until you become an expert on it. Phase 5 is 6 months and more, and advanced fitness exercises. Basically, everyone return to sports by now, and we do with elastics. You can see here it's called the monster walk, where the patient is with elastic belt walking from side to side. We caught her in the middle. And I'm paying attention also for the patient. Prone position, challenge position, post-operative and return to function after sports and post-vertebral body tethering. So when I interviewed Dr. Peter Newton, Lauren Barron, and Michael Vitale, we spoke about it. And basically, this is what I got. It was about a year ago, by Dr. Peter Newton, who was the president of the SRS, to keep the patient in brace for 3 months and ask them to avoid extension, lateral flexion, rotation, basically the BLT, the bending, lifting, twisting. And after 3 months, I allow full activity and return them to sports as lib. Speaking to Dr. Lohner, also no BLT, 3 to 4 weeks post-operative, and encourage walking, kickboard, and swimming pool. And once the incision healed, and once the incision healed, in 6 weeks post-op, initiate physical therapy, emphasize on core strengthening, flexibility. He comments us and say that he likes the Schroth, so the patient can work on their alignment, posture, shoulder, etc. They can begin return to sport and dance at 6 weeks in a gradual manner and allow full sport participation by 3 months. And he mentioned that he have not had many or any football or ice hockey players, but would consider allowing them to return to sport at 3 to 6 months, if only a thoracic tether, but would urge caution and recommended that they consider playing maybe a different sport. All other sports are permitted, and like that. And Dr. Vitale, only difference is that we may need to focus on physical therapy a bit more, on shoulder balance when there is a proximal, if something come above or below. Any questions?
Yes. So with fusion, you can have an impact above the fusion in terms of the curves above and below. But if we translate that into, if we look at vertebral body tethering, since there's still flexibility along the levels that are tethered,
I heard you. I now understand.
Okay. Will
Okay,
you be,
so-
yeah, can you see improvement in curve correction throughout the spine and throughout the levels that are tethered as well with these exercises?
Okay. One, I don't have enough experience with that, so I didn't see long term or at all even a short term in terms of improvement myself. I worked among surgeons that didn't do vertebral body tethering and still don't do. So I don't have experience with that. From the biomechanics understanding of it, at some point, when the patient is finishing growing, the tether, whatever it achieved in terms of correction, that area going to be auto-fused. So the tether is not a forever flexible, it's not a flexible. That area, they correct it, okay? And this correction, from my understanding and speaking, it become auto-fused. So some people call it, I think, the flexible surgery, but I heard debate between surgeons, very good surgeons. Can you call it something like that or not? So I'm not sure if there's going to be how much movement or how much more stiffness in this area. What do you, from your experience with the surgeons talking about it?
Right. My experience is that, well, there are studies that show that with the tethering, the levels that are tethered, there is maybe up to 80% reduction in lateral flexibility, maybe about in the thoracic spine, maybe about 50% reduction in lateral bending flexibility in lumbar spine. But so far, even 2 years out, it looks, with traditional VBT, it looks like the discs are quite healthy still. And these are from just kind of recently published studies from the SRS, specifically in Germany. So I think, and the tethers right now they're not designed for adolescents, they're not designed to last for many, many years. And oftentimes a rupture at 3 years, 2 years, whatever. So there is flexibility that comes back to those levels that are ruptured as well. So I think that I think autofusion, nobody knows what's going to happen in 20, 30 years, right? But I think if the tethers rupture and there's mobility coming back to the spine, and there has been bone growth modulation in terms of the vertebra, in terms of the disc being a little bit more rectangular instead of wedge shape, then I think the outlook looks pretty positive, right? So in terms of flexibility, I guess what I'm asking is that since fusion, there's no flexibility, and you are able to see correction curves above and below diffusion, to me, biomechanically, you'll probably be able to see more correction with a tethered spine, especially if you layer on top proper exercises for it. That's just my opinion, though, because no one knows what's going to happen in even 10 years, right? To you.
Good. From
Okay.
all my, yes, from everyone you can learn. Regarding people always ask, can I go back after the spinal fusion? Is there a point for me to do Schroth, just Schroth, or should I do Schroth and fitness? So I showed you before more when we went over these exercises. This is from the Schroth method. This is from the Schroth method. Here I'm using the Schroth principles. The bird dog on hands and knees and planks are using the Schroth principles, but these are fitness exercises, which are very, very, very important. So I use the Schroth principles all the time. I am still applying. I know the X-ray of the patient before the surgery. I have the X-ray of the patient after the surgery. And you know the areas that were concavities that you need to expand them. You know where was the prominence that you want to see if you can a little bit affect the ribs there. So I'm using, my mind is always, I know her curve type and her curve design. So I work with that. And I think it's very important to actually, after the fusion, more, in my opinion, Derek, is to bring the patient to do more of a fitness exercises, applying the Schroth principles. Why? There is something about, I am doing the Schroth method because I have scoliosis. I did the Schroth method or exercises for years in order to try to avoid surgery or to correct or to prepare myself because it works on the curves. Now, so it's almost it's like a, you know, I have a condition and I treated it with these exercises. And now the patient did everything they could. They had a surgery, they fixed their spine. I want them to feel that, you know, you're back to normality. You finish even with the bracing. You finish with the surgery. You are normal. You're doing the best you did the best you could using the Schroth. Now go out, live a normal life, do fitness exercises with attention, with respect to the fusion, with knowing what to do, but enjoy your activities of daily living. Derek, the Schroth exercises are not for fun. They are not for joy. And most children, and even adults, they don't do it because they want to do it, like going to Pilates, yoga, fitness, whatever, recreation, sport, and fitness you can give me, you can name. So, you know, it's a therapeutic modality. And now go out, you're strong. You need to strengthen your body. You fixed and you need to strengthen and keep all, you know, the side, whatever I showed before that can happen, we need to keep it from happening. But you can do it with fitness very well, applying the principles which are not complicated, okay, which is really not complicated for that patient or in general. And yes, so this is my statement on that. So when I work with patients, I always combine Schroth and fitness, and Schroth and fitness, and bring them slowly to return to their loved recreational or sport activity. But if we talk about Schroth, some therapists ask me, should we use the belt and do this exercise, which is great for elongation and expansion, using the traction belt, something that is a dilemma. And I asked Dr. Lenke, and he said that he have no objection to any of these, the traction, the belt, the hanging from the bar, but you need to know what you're doing and why are you doing what you're doing. And that is the key. Every therapist and person, when they do something, they need to know why they're doing it. So what is the reason to hang? Preoperative, lengthening of all the tissues, straightening the spine with a caudal downwards force of the weight of the body. Preparation for the exercise, lengthening the concavities, lengthening the neural tissue, the veins and the arteries, you know, preparing for being more elongated. After the operation, it's already fixed. Why do I need to go like that and stretch? And what am I going to stretch? No need to stretch the operated area. But yes, maybe I want to lengthen the lumbar spine, maybe the upper thoracic. Maybe I love this position that you see myself doing here now. Basically, the distance between my ears and my shoulders are large. So I'm not hanging here. I am actually at the end of pulling myself up with a straight arms. So hanging is passive when I will let go and sink down. Then my shoulder will be, or my arms will be next to my ears. But when I lower my arms down, there is a lot of shoulder activation here, and neck elongation, and facilitation of the erector spinae. And then I need to maintain my belly, my abdominal upwards, because typically it wants to extend. So I have to do core stability. There is a lot to do here, but you need to know what you're doing and teach the patients what they're doing. This is what my goal when I do that exercise or teach my therapist. Same thing with the belt. There is no need to traction belt here. But if I put the belt here to let the patient feel the stability of the pelvis, where I designed the patient in this position, and I see that now from the tailbone to the tail of the hair, there is a straight line. Then the strap can stabilize the pelvis and the patient get the sensation of it. So for that is okay. A post-operative and using the Schroth, we work a lot on pelvis correction. We have a few, 3, 4, 5 pelvis corrections. So it's something that we use. For example, in this patient, see her on the left side with the pelvis to the right and the trunk to the left.
Good. Inhale.
And then she sits here.
Breathe in, open the right side. Breathe out, lifting the foot, activating.
Here she's sitting, and I guide her how to maintain on the ball with the balls, with some leg lift, some maneuver that we do. And look at her here, and immediately look to the left side. So much improvement doing, and she works like that, and she stabilizes herself. Also in standing, I put a yoga block to her left hip. She is not fused to the hips and the pelvis, and she pushed this yoga block to the wall. She's standing upright. She's moving her trunk and expanding her right side so she can move the trunk from left to right. No need to work on pelvis and trunk alignment or correction if the patient, 1, have a fusion to the pelvis, as you can see here, and 2, if it's actually, you see, a very good alignment. So I don't need to do anything about that. Elongation, this is the Schroth standing I showed you before. Here you can see the patient. Basically, that's the girl with the upper thoracic adding on phenomena, which she developed a curve above her thoracic fusion. And when I sit with her, my right hand is always on her right elbow here, and she's moving her upper thoracic into my hand on the right side. And that's straighten. Look at her neck here. That straighten her neck compared to the neck tilted on the left side picture. And then we work also on the rotation, and we work on expanding of the ribs of the left side that's still kind of stuck in exhalation. And then we're working on diaphragmatic breathing and chest breath and manual therapy, opening her trunk. And I work on the soft tissue between the ribs. And on the soft tissue in the lumbar region, on her right concavity. Okay. And then with adults, also this one is about 40 or 50 years post-operative in her own home, lying down on the side. This is the side of the concavity. And the therapist can basically, we have an exercise, a short side-lying exercise. But before that, a lot of manual work. This is her collapsed side when she stands. When she lies down, it's nice on the ground. The patient breathes to this area while I am also opening the soft tissue. Here you can see the patient practicing balance and stability on the ball with elastic belt around the concavities, right lumbar, left thoracic. Also with the arms, activity and workout and the core. And she's breathing into the concavities that were there before the surgery, but still will gain a benefit from breath. And this is also someone for scoliosis, but you can see now the need for her trunk become a little bit more kyphotic. In the picture, the X-ray from 2008, we can see the kyphosation above the last fused area on the top starting. So we're doing exercises where, I'll just bring her down a little bit. I'll try to find it, okay. Maybe better here, let's see. Well, she pulling the elastic belt, and this area right here where it is protruding back, now it's going forward from the activation and the bra is coming out to us. Breathing in, obviously it filled with air, so you can see the protrusion of the fusion a little bit and the kyphosis that happened. And then when she activates laterally, it's improving her kyphosis. Same thing here, but I will skip it. But again, an adult post-operative doing wonderful. Same. This is about the prominence and the shoulder blade. We're using this as a short exercise called the unilateral one side pull out elastic belt. It's about applying all the principles here, knowing the stability of the pelvis and the trunk and where to expand and elongate and all of that. And then using elastic belt to basically realign the scapula. Look at it again on the left side picture and compare immediately while she was working. So the more the patient exercise, activate, bringing the scapula into the right alignment, the better, you know, it's practice makes great. Same thing here and here. These pictures of my patient from Ghana, which I wanted, again, always say thank you for coming to the world of scoliosis from here, from this traveling. And again, a nice workout. I'm not sure if it's going to work. Let me see. These are all the post-op in Ghana, Africa, right after the surgery. Some of them 1 day, some of them a week, some of them a little bit more. And we teach them upright, breath. Later on, some squats or coming on the toes, lengthening, trying to let go of their arms, functional activities. Okay, I will end the presentation here.
Okay, I guess a couple questions now. Because it's a physical therapy, oftentimes patients will, I shouldn't say often, but are you only going to get results as long, just like any other exercise, are you only going to get results as long as you do the exercises? So for instance, do you have to keep doing Schroth forever, or is that why you manage by transitioning them into fitness so they can do something they enjoy as opposed to going through more of a functional, not as enjoyable Schroth protocol initially?
Excellent question. I would say I start post-operative I review the Schroth principles. I see what exercises are now more applicable for them. Then I like to transition to more functional fitness exercises using the principles, but less of the Schroth as an exercise for the long term.
Because it's so hard to make.
You know, unless it's an area like the lumbar that we always want to, if they feel the thoracic and the lumbar have a curve and we need to work on the curve, as long as we work on it. But even then, if I use the Schroth, also go to fitness.
Okay. Great. All right. Hagit, I think it's a terrific presentation, lots of detail, lots of videos. Thank you so much for your time.
Thank you, Derek. Thank you. Great questions, and it's not. I'm very happy.
All right. Have a terrific day, and we'll talk to you next time.
You too.
Thanks very much.
Bye bye.